question that I was formulating there while you were talking is you were talking about the high pulmonary pressures. And all right, so that translates into us in the field. We got this kid who's just refusing to oxygenate despite us bagging them and increasing the FiO2, the oxygen concentration. Is PEEP appropriate for the newborn, or is that something that we should only be thinking about in our kiddos and our adults?
So all newborns should have PEEP. And if you think of CPAP,
That's my thing.
I know it is.
Yeah.
if you think of CPAP is just PEEP, right?
Yeah, of course.
We can increase it some. We don't tend to increase it a lot. So we usually start with bagging with something like 20/5. When you're having difficulties with ventilation, and you will know that by your heart rate not coming up and by not having good chest rise, that's when we start to go up on our PIP. If you're having respiratory distress, so a baby is retracting quite a bit, or you're having some difficulties with oxygenation, we'll tweak our PEEP a little bit in the delivery room. We'll tweak it up to 6 usually. I've never thought of it in terms of overcoming your pulmonary pressure, but
Yeah.
you can definitely help with oxygenation by increasing your PEEP. I think a lot of that has to do with recruitment and having more open alveoli in order to exchange gas through,
Right.
and along with low compliance that wants to collapse in on itself. But
So I think to kind of restate that simply would be, you can start your cessation, you can start bagging, not necessarily needing PEEP.
Right.
And then if you're not improving, adding PEEP would be
that
one
was-
of
that
the
was-
steps.
well, you always need PEEP.
You said always PEEP?
So you're always going to
Always PEEP
have
at 5?
you're always going to have some degree of PEEP when you're bagging. So, and we start at 5.
I'm talking about putting PEEP valves on the bags.
We always have PEEP.
Okay. There you go.
Yeah.
Always PEEP. Absolutely, yes.
Yeah,
Always PEEP.
That is sadly, I put it on the floor here.
There's one
but
up there,
yeah,
too.
that
Palmidine makes a great product.
oh, here we go. It took so long. Often in the initial resuscitation in the adult,
We don't have PEEP to our
there's
bags.
often not PEEP, and that's
So-
where he's got his pet peeves. He talks about. I always somehow figure out a way to slide something about a PEEP valve in there. So
So remember, the newborn lung is going to come out completely deflated, right? And you have to inflate it.
Expand it, yeah.
And what you're doing with your initial breathing for the baby, so what you're doing initially is first starting to help the baby develop their FRC, or their functional residual
Reserve,
capacity. So that amount of air that is always going to be in the lung, even at the end of exhalation. And that's that initial inflation of your lung. And babies have lungs with very high resistance, or not high resistance. They have lungs with very low compliance. And so what that lung wants to do is collapse in on itself. And PEEP is going to be the measure that helps get that lung open and keep it open. And as soon as you so if you have a baby on CPAP, or as soon as you take away your PEEP, that lung is just going to collapse down. You have to do the work to reinflate it all over again.
And we talk about that in the adults too, that once you break that mask seal, if you're doing BVM, you've now
Lost
lost
it
your
all.
PEEP. You need to re-recruit your alveoli by keeping that mask seal on and be able to keep that PEEP in place. Always PEEP. Got it.
Always PEEP.
Always PEEP makes me happy. Now if we can just get everybody to get
So
on board.
in your world of pediatrics, where is the best? Is it enterosis or vascular access?
I was getting to access.
What is
thank you.
your best
We've got
options?
drugs and access to talk about here.
So certainly you could put in an intravenous line. If you are doing initial newborn resuscitation, your best bet is always going to be umbilical access. So we brought my little umbilical cord, but your best bet's always going to be umbilical access. So if you have moved past, so you've started with bag mask ventilation and your heart rate is still low, so you've moved on to intubation and you're doing now or supraglottic airway, but you've moved into artificial airway and you know you have effective ventilation for 60 seconds and your heart rate is still low, then your next move is going to be to compressions. And if you are doing compressions with effective ventilation and your heart rate is still low, your next move is going to be talking meds, epinephrine. And NRP is going to be simpler than any of the other resuscitation programs. So NRP, we only have one medication. So if you think you've had something like blood loss, like acute blood loss, so you've had an abruption, then you can fluid resuscitate. So the next step's going to be fluid resuscitation with either crystalloid, if that's the easiest thing to get to you, so normal saline bolus,
Likely.
or blood. And while you are, so in order to do that, you're going to need vascular access. And in order to give epinephrine, you can give it two ways. You can give it down the tube, or you can give it through a UVC, or an umbilical venous line. So in NRP, these are things you're going to want to do quickly. And so you're going to want to get quick, easy, secure access. And in these babies that are first born not having, and they're down, you're not going to be able to get peripheral access quickly or easily. And so what you're going to want to do is take something. If you have umbilical tape, that's great. If you have something else you can use to kind of tie around. So you're just going to tie around, if you put it here, it fits in here. So if you imagine your cord sticking out of your baby, and this is kind of a lot of it, and you have a clamp on this end, you kind of bait it on quickly, tie. So tie at the bottom, so once you cut off your clamp, it doesn't bleed everywhere. Cut. And then when you look at it, you should have 3 vessels staring you in the face. Some cords will have 2 vessels staring you in the face, but you'll have 3 vessels staring you in the face. 2 small vessels
ones,
that have thick walls, and 1 big vessel with a thin wall. And the big vessel with a thin wall, especially in a baby that is sick, is usually gaping open right at you. And that's going to be your best source of venous access. So if you have access to an umbilical venous catheter, you put it in just to blood return, and then you can use it. Make sure that anything you're putting in there, make sure it's flushed. It's always a good rule.
I think that's important to say, because when we put in drop central lines, right, they're always flushed and we've got fluid in them. When they're inserting IVs, they're never pre-flushed.
Correct, they're dry.
Yeah.
So I think that's important to say
That, yeah.
to flush it with saline,
Is charge the catheter with.
so we don't do an air bolus.
Yep.
Yep.
An air embolus. Yeah.
Yeah, and just remember, this is a big central vessel.
Yeah.
So you literally just, this is an angiocath, but you literally just put it in. If you have a longer catheter, you put it in, you pull back till you get blood return, and then you can go straight through it. It is easiest if you put a stopcock on it. But if you don't have a stopcock on it, you can just kind of pinch off as you're changing things and do it that way.
They should have J loops, which should have, as
Click
long
stops.
as you're okay with it, the valves on them.
Oh. And always just when you're changing things, pull back on it, make the air come back out of it, and then you can make the air come back out. It'll rise up to the top, and you can flush through it again. So that's where you can put in your fluid bolus. That's where you can put in your blood. That's where you can put in your epinephrine. So that's in a code situation or in an NRP situation going to be your source of vascular access.
Okay.
If for some reason you cannot get a UVC, say you have a baby who's not directly, you're not doing NRP, well, you'd still be doing NRP. Say you have a baby who's not a brand newborn, so a baby who has been home, say, or a baby who's more than a few days old and your cord's not there, or just an older baby in general. If you have a baby where you can't get peripheral access, your next line is going to be doing an IO. And unlike in older children and adults, we actually use the medial tibial plateau for our IOs. So you're not going to want to do the humeral head like you do in older people.
adults,
it's always
yeah.
going to be in the tibia.
All right. So always tibia, no humeral heads. Can it be a powered IO, or is this something we should finesse by hand?
We have the drill.
You have the drill? No, I mean that's
That's what we have.
all I
yeah.
needed to hear, right?
Yep.
Didn't know if there was a preference to,
No.
even taking the same needle, right, and then just hand working that in.
So
or-
you could, and that's
of course you could, but
so that's the size you're going to be using for our babies, and it makes sense, right? So you're either working it in, or once you're using the drill, you just use the drill until you don't feel resistance,
pop,
and you
yeah.
stop.
I think it's important to say that you don't want to put pressure on it. You just want to
work. Let the drill work.
Hold it down, but have the drill do the work. And once you feel that resistance, you stop.
Stop.
Yep.
And leave it in place, and that's as deep as it needs to go.
The resistance will just go away.
Yep. And that's true. Neonates, children, or even adults. We don't need to drill it all the way in down to the skin. As soon as you lose resistance, it's in the right place.
Yeah, we've certainly covered that before on some of the other talks. The point here that we really haven't touched on is glycemic management or glucose management of the neonate. I guess let's just get right to the point. Are the values the same, or am I looking for...
They're much different.
Much different. Okay.
Oh.
So you're telling me that an infant's not a little
Adult?
A little adult?
Doesn't come out with 80, 100 BGL.
No.
So
It probably comes out with 80 to 100 BGL, but it's going to drop really quickly.
Consumes it quickly.
So after about half an hour, this is something you're going to want to check.
Okay.
And the reason it's coming out with normal glucoses when it's born is because it's getting continuous glucose
mom.
infusion from the placenta.
Yeah.
But once a baby is born, they have an acute cutoff of that continuous glucose infusion, and their pancreas is still used to seeing that. And so babies are born in a relative state of hyperinsulinism.
Okay.
And there are genetic reasons for prolonged hyperinsulinism, and there are some kind of environmental or some fetal environmental, so diabetes, reasons for hyperinsulinism. But even in a normal baby, you're going to be in a state of relative hyperinsulinism because you've been getting a continuous glucose infusion throughout your pregnancy. So after about half an hour, you're going to want to start checking your glucose. The target that we're using for glucose is actually 40.
40.
You may want to ride that a little higher just in the field in an EMS just to give yourself some wiggle room.
Just padding it.
Yeah, so shooting for 50, 60 just to pad it. So a baby with a glucose of 45 who is otherwise well, nothing to worry about. If you have a baby who is sick or who has needed resuscitation, those are always going to be babies who need continuous glucose infusion anyway.
Got it.
But the question is really going to be, do I just want to start continuous glucose infusion or do I need to correct? And so if I'm less than 40, I'm going to want to correct.
Okay.
And the way to do that is going to be with D10 boluses.
That's our traditional 2 mLs per K.
Exactly, 2 mLs per kilo. And you're never going to want to use anything more concentrated than D10 in a peripheral baby vein.
Can that be given umbilically?
Mm-hmm. Yeah, anything you can give peripherally, you can give through a UVC. The opposite is not true. So we talk in neonatology about glucose infusion rates, or we call it GIR. So it's thinking about the amount of glucose that a baby needs. The language of glucose in a neonate is going to be the glucose infusion rate, which is milligrams per kilogram per minute of IV dextrose infusion.
Okay.
A typical neonate's need for glucose infusion is going to be 4 to 6 milligrams per kilogram per minute. So when we're talking about starting IV fluids just to meet their regular metabolic demands, you'll hear us talk about in a newborn starting at 80 mLs per kilo of D10. And the magic of D10, and usually water in a newborn, but the magic of D10 water at 80 milligrams per kilo, at 80 mLs per kilo per day. So the magic of D10 water at 80 mLs per kilo per day is going to be your kilograms is going to cancel out as you're dividing this. So D10 water at 80 milligrams. D10 water.
It's a word salad. It's okay.
Oh my God. The magic of D10 at 80 or at 80 mLs per kilo per day is going to be D10, 10% dextrose at 80 mLs per kilo per day is always going to be a glucose infusion rate of 5.5 milligrams per kilogram per minute.
Per minute, okay.
And so you're hitting toward the higher end of that 4 to 6 milligrams per kilogram per minute of normal metabolism in a newborn.
Huh.
So you figure your fluid needs are about 80 mLs per kilo per day, and your glucose needs are going to be 4 to 6 milligrams per kilogram per minute, and you reach the happy medium of D10 to meet 5.5
yeah.
milligrams per kilogram per minute at 80 mLs per kilo per day.
Neat.
It's almost like we could do that. I think something worth pointing out that with the babies and the lancets, you're probably not going to want to use a finger. Very
You
tiny
beat
little
me.
finger.
You beat me
Just
to it.
beat
To
me
the
to
heel
it also.
sticks.
Yes.
So,
We were talking off camera about using things in a pinch
Mm-hmm.
in the resuscitation, more so for the EMS side of things, where we might not have a whole cart full of or a whole room full of
Of neonatal sized things.
purposely sized things. And the what you had shown us earlier was you just using an angio. Just
Yeah.
using the catheter, not the,
Yes.
the catheter, not the needle and catheter.
Do not use the needle.
Yeah,
But
I was. Oh, I'm gonna stab somebody with
yeah,
that.
this was the 16.
This is a
14?
14, but yeah, just
Yeah.
using the catheter part of that.
So-
Sterile, not gloving it like I just would have, but
So it's going to be a little tight in here because you've got
Yeah.
plastic on plastic.
But-
But you can prime this and you can put a syringe on the end. You can even put a stopcock on the end. But so prime.
prime that with saline or
And so you betadined and you tied and you've cut and now you're inserting your
Slide that
UVC.
in
So you're
there.
putting it into the thin-walled, big open vessel and you just slide it in while pulling back until you see blood return. And once you see blood return, then you can use this for all of your resuscitation. You can use it for
Nice.
fluid resuscitation. You can use it for epinephrine. You can use it to run blood. You can use it to run your IV fluid. You can use it for antibiotics.
dextrose.
This is a central line.
Nice.
for how long? I mean, obviously, we're not going to. It'll
So-
be very acutely for us, but
So we will, when you bring a baby in with the UVC that you've placed in the field, no matter how sterilely you've tried to do it, we will assume that it is not sterile.
sure.
And so we will pull it out and replace it. Also, you're not going to want to use, so this is what we would call a low-lying UVC. So this is going to be a UVC that is going in just to blood return. It's going to be sitting below the liver, and anything that you're putting in it is going to be going up, and in addition to going into systemic
circulation.
venous circulation, it's also going to go into portal circulation.
That's a good point.
And so, in order for us to use it as a true central line, we like to get it through the ductus venosus, which again is part of fetal circulation,
Right.
but through the ductus venosus, up through the liver, and have it sitting just above the diaphragm. And we'll use a line like that for, I mean, in a pinch, if we've not had anything else where baby's unstable, we've used them for longer. We've used them for as long as, generally, we like to use them for no longer than 7 days, but
Wow.
we've used them,
That's longer than I anticipated.
That's
so,
longer than
yeah.
I expected. Yeah.
we've used them a little bit longer if we've had to. If we anticipate needing it for longer than that, then we'll usually put in a PICC line and pull out our umbilical line.
And then some other things we've been talking about off camera is in a pinch is we may. I would hope this day and age most ambulances have an infant bag valve mask, but I can at least pretty much assure we would have a pediatric size. What
Yeah,
is-
do we want
what-
to talk about bagging in general?
Yeah.
So it's always going to be easier to hold your bag with two hands and have somebody else,
Yep.
or hold your mask with two hands, and have somebody else bag for you. You want to get your baby into a good sniffing position, so not hyperextended, but not flexed either, and a flexed chin is going to be a closed airway. So a nice sniffing position. Babies can be on the floppier side, and sometimes you're helped by a shoulder roll. If you don't have a shoulder roll, I often like to use my middle and
I
or
see
my,
you.
my ring and pinky fingers to make my own shoulder
over
roll.
here. Yeah, you're
Yep.
using it as a ramp.
Yep. So I'm making my own shoulder roll there, and you want to kind of, rather than pushing the mask onto the face, try and pull the head up toward the mask.
Nice.
So you get a good seal, and so NRP talks about the C and the E. So I don't have a seal, I just felt it come out that way. But NRP talks about the C and the E. So the way you hold the mask, if you see it, there's the C
See?
and there's the E. So one finger under the chin and your index finger and your thumb on the mask. So once I have a good seal, yeah, if you want to put some air into there, I still don't have a good seal, but this is a good example. So if you put in a little, yep, so you see you have chest rise there. So you're going to want to do it when you don't have a manometer. You want to do it just to chest rise. So what you were saying before, though, so I'm having a hard time getting a seal. Sometimes if your face is just the wrong shape for your
Yeah.
mask, or a mask is too big for your face, one of the things you can try is turning it around. I still have a link. There we go.
I think it's important to say, like, to have that communication between who's
Yeah.
who's
Yeah,
holding
yeah,
who's bagging.
exactly.
Like, I feel a leak. I feel
I
a
still,
leak.
I still
Mhm.
like
because
it.
you're
I'm
doing such
repositioning, yeah.
small volumes
Finite, yeah.
that we
If-
don't want to cause barotrauma.
If you
Which
only have
yeah.
if you only have an adult mask,
There we go.
it's not ideal to have the eyes inside your mask, but if your choices are eyes inside your mask or unable to ventilate, then you can put the mask over the whole face. And it'll take a little bit of manipulation, but I can even see it down there. Okay, try that.
So-
And if you're having just a hard time with the masks you have, though it's a little slow, so we want to practice that, but we can do it through something where you can see. If you're having a hard time with the masks you have and you don't have anything small enough and you have the ability to put in a supraglottic airway,
Supraglottic, yeah.
you can put in your supraglottic airway. So this is your eye gel, but just literally just push it into place, put on your mask, or put on your bag, and see, there's your chest rise. So then you're going to want to breathe at the speed of 40 to 60 breaths a minute. So breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3, breathe, 2, 3. Good. And it's interesting having people coming from the adult world, because usually what I see in the delivery room is people going.
That's how it usually goes.
Honestly, that rate seems what.
Like a heart rate?
No, it's no.
Heart rate.
It seems like what I'm coaching myself down from in the adult population,
yeah.
right?
Mhm.
It's like it's what I would naturally go to if
Feels
I
odd,
didn't
doesn't
know
it?
that it actually hurt people, hurt adults, you know.
How important are fontanelles to you?
Very.
It's a loaded question.
So
why?
So babies should definitely have them. So
The
Okay, let me rephrase
the
the question.
assessment of
What do fontanelles tell you about the patient's condition or lack of?
So in a newborn, fontanelles tell you most about fluid status. So just to think about the baby skull for a second, or think about anybody's skull, but the skull is made of a few different bones. So you have your frontal bone in the front, your frontal bones in the front, your parietal bones, your occipital bones. Okay. And your your temporal bones are there too. I just left them out. So you have your frontal bones, your parietal bones, your temporal bones, and your occipital bones. And they are all, in us, they are fused with suture lines. In babies, they are open. And the reason for that is that they can slide around and go over each other and overlap to allow the baby to come down through the pelvis and come out. Think about them as the tectonic plates in the earth and how
Yeah, no, that's great.
they slide over each other. So the fontanelle is a space between these bones before they have fused, and as the bones fuse, eventually the fontanelle will fuse too and go away. But it is a little opening between the bones. There's an anterior one and a posterior one. The anterior one is really easy to feel. The posterior one's a little bit more difficult. But it gives you a good idea of a baby's fluid status. So a fontanelle, when you feel it, and you know what a normal fontanelle feels like just by feeling a lot of fontanelles. But having felt a lot of fontanelles, a normal fontanelle is going to be soft, so it won't be tense, but it'll be flat. So when you're feeling the head, so you shouldn't be able to see it. When you're feeling the head, it should look flat. And when you give it a little, not hard press, but when you give it a little pressure, it should be soft. If a fontanelle is sunken, that'll tell you that a baby is probably dehydrated. If a fontanelle is bulging or tense, that tells you, for some reason, you have increased intracranial pressure. So that can be from things like hydrocephalus. Sometimes our preterm babies have intraventricular hemorrhages, or they bleed into the spaces in their brain that should contain CSF. Once you've bled into them, you can get obstructive hydrocephalus. And so it's kind of a good measure of obstruction and if something needs to be done about it, or at least a screening tool, not really a measure, but it's a screen for obstruction, or a screen for increased intracranial pressure from obstruction or from obstructive hydrocephalus. It can be from meningitis. So meningitis will give you increased intracranial pressure. It can be from more nefarious things like trauma. So a bulging fontanelle is bad. A sunken fontanelle is a sign of fluid loss or of dehydration.
Yeah, and I love to teach to the point that, fluid loss can be not only hemorrhage, but also, just diarrhea or vomiting, respiration. So you got to
in a newborn,
careful.
It can even just be evaporation.
Yeah, that's a good point.
Yeah, excellent. Yeah, going back to your putting the preemies in a bag.
Yeah,
yeah. In the acute resuscitation parts, or anything else we need to talk about on this episode? We got a ton of stuff here that is definitely suited for another go around. But anything we didn't hit in the newborn resuscitation as the high points?
I think one thing we should talk about, because we talked about picking where we're going to take these kiddos, right? If they're just born, they should go to, and you can get them to a NICU center, that's where they should go. If they're full term and they're sick, a place that has OB services and will have some level of neonatal care there. At what point, or what things should we be looking for, whether it's just a newborn that was just born at home, or we're in the field, when should we be calling for a helicopter versus just transporting via ground to the nearest ER?
This may be my own ignorance, but can you get a helicopter in a baby that's born at home or just the field?
Yes.
So I will speak to a recent case where they were reluctant to fly because they couldn't thermoregulate the kid, and the kid was term and improving, right, and doing well, and they said we're still going to help, and they got on and they went by ground to a local hospital with it's Geauga, whatever level that Geauga is.
Geauga's a 1.
Is it 1?
Mm-hmm.
I mean, they went by ground, and their primary consideration was kid's getting better. I can't thermoregulate him very well in the helicopter.
I would say most babies can be safely transported by ground, especially in...
Sorry.
It's
nice
okay.
catch. Jeez,
Thanks.
That was impressive.
Especially in our area where we have a relatively high number of hospitals in a relatively small geographical area. And so even if you are going to a freestanding ED without OB services, and having to transport from there, it'll be safer to go by ground to where you are, stabilize in a hospital rather than in the field, and then transport again.
And every ER's got warmers. Like we have the equipment to be prepared for these deliveries.
Isolates.
We don't have isolates, but we have warmers that we can warm baby up after they arrive. So
what hospitals or what helicopters are really good for is decreasing your out of hospital time. They don't necessarily speed up your whole transport. And sometimes they can actually slow down your whole transport. So when you're talking about having to get a helicopter from a helicopter pad or from an airport to a place that may not have a pad or to a place that you can land safely. Sometimes babies have to be transported, or patients have to be transported by ground to a place where you can take off with the helicopter. And with our geographical area, there aren't a lot of circumstances where that is going to be faster. So unless your baby is so ill that you're concerned about really needing to minimize the time that you have them out of a hospital, around this area, ground is generally going to be a reasonable way to transport. When we're talking about intra-hospital transport around here, our critical care transport team at this moment is using only ground, even with our sickest of babies. As we get the ability, we probably will go to using air when it is available to us. And I think that'll have a lot to do with the ability to get to babies faster. I don't know that it'll get babies back faster, but it may help us get to babies faster.
Sure.
We have talked before about potentially using it as a resource to get providers to the baby,
yeah,
even
They're
if
a specialist of the
Yeah.
baby.
even if the baby comes back by ground.
By ground, yeah.
One thing to be aware of with the helicopter is that a helicopter is not always a good choice, even if it is going to make your transport shorter. And the best example I can think of with this is with a baby who has a pneumothorax. So as you use the helicopter, you're increasing in altitude, which is going to decrease pressure and ultimately make your pneumothorax bigger, which could ultimately lead to cardiovascular compromise in the helicopter, which is not something you want to deal with.
Yes.
And a tough place to manage it.
Yeah.
Yep.
I'm very much so.
So sometimes babies are born with anomalies, and sometimes those are major anomalies that take some consideration for the initial stabilization and for transport. So, two important things to think about are going to be open abdominal wall defects and spina bifida, or open or closed. But so open abdominal wall defects or defects in your neural tube. So things like spina bifida. The biggest consideration for these is going to be bringing these babies back safely while keeping either your abdominal wall defect or your spina bifida defect moist. So the same way that we covered a preterm baby, so a baby less than 32 weeks, the same way we wrapped them in plastic wrap or we put them into some sort of plastic bag, we, in the delivery room at the hospital, use what we call a bowel bag, which is literally a sterile bag with a drawstring. And you can put the whole baby up to above the level of the defect into the bag. You want to pour some sterile saline into the bag and just make sure that that stays moist. So as you're driving, if you're driving a longer distance, you may want to open it up and just pour some more saline in there
Hopefully
occasionally.
warmed saline, hopefully.
With a spinal defect, you're not going to want to transport that baby on their back. So you're going to want to transport them on their sides or on their belly. With an open abdominal wall defect, so an open one is going to be a gastroschisis, one that's covered with a membrane is going to be an omphalocele. Omphaloceles can sometimes rupture. And so one that was previously closed can look open. A big consideration is going to be not rupturing the sac, either really an anterior or a posterior sac. So you don't want to rupture an omphalocele sac, or you don't want to rupture a spina bifida sac. And in all of these cases, the easiest thing to do is just put them in the bowel bag or put them in the bag you have. Keep it moist.
Okay. And that would go back to your previous statement of, in the absence of the perfect tool, saran wrap or something.
Saran wrap.
Something.
Keep it moist.
Yeah.
Do what you can to not compromise the bowel if you have something like gastroschisis. So trying to keep it kind of loose and mobile as opposed to creating kinks that can affect the blood supply.
So loose wrap, but this is what I'm hearing is if I'm improvising with
Loose plastic wrap, saline.
With all of our episodes, we'll have show notes up on our website.
as always.
We'll have some diagrams up there, some more support materials as well that you guys can go look at prehospitalparadigm.com.
That's right. All right. Doctor, thank you so much for joining us.
Thank you.
This has been great.
Thank
This
you,
is
yeah.
fun.
Thanks.